used to be at Baylor College of Medicine in Houston, and we had an ICU there that at times was 50% occupied with liver cirrhotics getting evaluated for liver transplant and being decompensated. So it's something I have a lot of experience with, unfortunately. As you all know, liver cirrhosis doesn't have a very good prognosis. So my learning objectives for this talk are that I hope that you, at the end, can describe and recognize the complications of liver cirrhosis that are commonly encountered in the ICU, and that you can manage an ICU patient with an acute variceal hemorrhage, recognize causes of acute kidney injury in patients with liver cirrhosis, diagnose hepatorenal syndrome. I'll spend a big chunk of the talk talking about that, and provide evidence-based guideline-conformed treatment of patients with hepatorenal syndrome, know what the prognosis is, and also diagnose and treat spontaneous bacterial peritonitis. So the complications of liver cirrhosis that we commonly encounter in the ICU are, there's quite a few, right? So I'm not going to be able to cover everything in 45 to 60 minutes. So I will focus on those that I think are most common and just briefly mention the others. And I listed them here. So variceal hemorrhage, ascites, the ICU we see typically because of the complications, especially spontaneous bacterial peritonitis or SBP. Hepatic hydrothorax, spontaneous bacterial empyema, I've seen that when the pleural fluid gets infected. Hepatic encephalopathy, HCC, hepatocellular carcinoma, and then two that are rarer, hepatopulmonary syndrome and portopulmonary hypertension. So mainly it's just to know about them. And most of these are complications of portal hypertension. And what's important to know is if a patient has any of these complications, by definition, they have decompensated cirrhosis. And there are a couple of complications of cirrhosis that don't make someone decompensated, and those are cirrhotic cardiomyopathy and just having a portal vein thrombosis. And I'll briefly talk about those at the end. And all of these complications, there are certain triggers or risk factors that can make patients get these complications. And bleeding is a very common one. Doesn't just cause the acute variceal hemorrhage, but can trigger the HRS, hepatorenal syndrome, can trigger SBP, bacteremia. Infection is often a trigger. Alcohol use, certain medications. Being dehydrated can make someone decompensate, constipation in itself. And obesity is not necessarily a trigger, but it is a risk factor for getting all of these complications. And I don't know exactly what availability of liver transplantation is in Tanzania or in the countries where you're at, but if anyone has evidence of decompensation in the US, we would consider whether they're candidates for liver transplantation. And just to put that in the big picture, we evaluate a lot of patients for liver transplantation, and only very, very few actually end up getting a liver transplant. So this is just a slide to remind everyone of the pathophysiology. I hope you can see the slide completely, since part of it is cut off for me here. So in liver cirrhosis, here you have the liver. So this little band, rubber band around the liver, it signifies that you get a mechanical distortion of the liver sinusoids, which are the blood vessels in the liver, because of the cirrhosis. And you get vasoconstriction, and because of those two factors, you have increased vascular resistance, which is the portal pressure in the liver. And the vasoconstriction is caused by decreased availability of the NO, the nitric oxide, which is a vasodilator, and an increased availability of endothelin, or increased production of that. And then the increased portal pressure leads to splanchnic vasodilation. That's here in the center. And the splanchnic vessels are the ones that drain the gut, the pancreas, the spleen, etc. And because of increased portal flow, you also get a further increase of portal pressure. So it's kind of a perpetuating cycle. And because the pressure in the portal system in the liver is too high, the blood needs to go somewhere. So the blood goes through collaterals, and those are the varices that then can bleed. And because of the increased pressure in the portal vein, you get the ascites. The splanchnic vasodilation additionally leads to shunting of cardiac output from the systemic circulation to the mesenteric vessels. So you have more blood in your gut, basically, and that means you have less blood volume in other organs, like the kidneys. And that leads to the renal hypoperfusion and systemic hypotension. That's why if you have a cirrhotic, they all have baseline low blood pressures. And then the renal hypoperfusion, because the blood is in the splanchnic vasculature, not in the kidneys, and then our body thinks that, or the body of a cirrhotic thinks that the total volume of the patient, blood volume or intravascular volume, is reduced. And what do the kidneys do if there's not enough volume? They try to retain volume, right? So the RAS, the renin-angiotensin-aldosterone system, gets stimulated, activated, and tells the kidneys to retain both sodium and fluid. And that leads to the systemic volume overload that we see in the cirrhotics that can have pretty severe anasarca everywhere. And then in addition to the activation of the RAS system from the renal hypoperfusion, because of systemic hypotension, the sympathetic nervous system gets activated as well. And then the heart gets stimulated and you get hyperdynamic circulation, high cardiac output. That's why cirrhotics typically have a high cardiac output, which is basically their cardiac dysfunction, the cirrhotic cardiomyopathy. And then just a reminder that the portal hypertension that's causing all these complications is not only caused by cirrhosis, though that's the cause that we see most commonly, but it can be prehepatic, hepatic, and posthepatic. And then hepatic can be before the sinusoids, in the sinusoids, or after the sinusoids. And there's a whole bunch of diseases. Those that I think are fairly common is the portal vein thrombosis. Maybe in some countries, not in the US, schistosomiasis, obviously liver mets, amyloidosis, polycystic liver disease, we do see that. And then post-hepatic Budd-Chiari. And then congestive heart failure. That's why all our patients, or many of our patients with longstanding heart failure, they get congestive hepatopathy. And if that goes on for a long time, they get cirrhosis. So just checking who sent me a chat. Okay, someone is saying voice up, please. Can you hear me okay?
Yes, we can. Yes.
Okay, all right. I saw a message that said I need to speak up. All right. So the variceal hemorrhage is common. It develops in half of the patients with cirrhosis. At least they get varices, and then many of them end up bleeding. And the annual rate has been described as 5 to 15%, so up to 1 in 6. And the more severe your cirrhosis, the higher risk of getting variceal hemorrhage. And the patients that are already being treated with a beta blocker to reduce the risk of variceal bleeding, and then they still get variceal bleeding, they have a poor prognosis. The mortality, despite all the treatment we have available, is still pretty high, 15 to 20% 30-day mortality. And the symptoms you all know, it's a patient throws up blood or has melena. If it's a very brisk bleed, can even be bright red blood per rectum. And just remember, not every cirrhotic with a GI bleed has a variceal bleed. It's certainly the #1 differential diagnosis you need to think of. But it could also be a bleeding peptic ulcer if the patient took a lot of NSAIDs, which are contraindicated of cirrhotics, but not every cirrhotic knows that. Or if they, have some other cause of bleeding. And the only way to really diagnose it is obviously by doing an endoscopy. So varices, the most common location is the esophagus. We see a fair amount of gastric varices as well in the stomach, and those are more difficult to treat. And they require an advanced endoscopist to treat them. And then rarely you can have ectopic varices in the small bowel. They're really difficult to diagnose. And you can also, independent of cirrhosis, have isolated gastric varices. And I've seen a couple of patients with that. Particularly, I remember one young woman, she had familial hypertriglyceridemia, and because of that, recurrent bouts of pancreatitis, and ended up with a splenic vein thrombosis and gastric varices from that. She didn't have esophageal varices. And this is just a picture of what it looks like when a GI specialist looks at the varices. So here is very subtle, small varices. Here, very large. Everyone can see these blood vessels. And then another complication of portal hypertension that the endoscopists often see is the severe portal hypertensive gastropathy. And you can see this punctate mucosal hemorrhage, and you can see this kind of edematous here. I got these pictures from an article in Mayo Clinic Proceedings that was reviewing the complications of cirrhosis. So if anyone wants to read more about that, I recommend that article. So risk factors for variceal hemorrhage are the more severe the liver diseases, the higher the risk of having a bleed. Obviously, one classification is the Child-Pugh classification. The size of the varices, the larger, the higher the risk of bleeding. And then something called a red whale sign on the varices. That's something that's seen during endoscopy. So now I want to go through a case and talk about treatment based on this case. So we have a 43-year-old woman. She has a history of cirrhosis from non-alcoholic steatohepatitis, NASH, complicated by esophageal varices and mild ascites, type 2 diabetes, and depression. She comes to the emergency room, has 2 days of melena, and had 2 episodes of throwing up red blood. When you go into the room and examine her, you notice that she's dizzy when she sits up. And her systolic blood pressure drops from 95 lying to 70 sitting. And her heart rate increases as well, gets more tachycardic. So the nurse displays IV access, and you prescribe 2 liters of isotonic crystalloid resuscitation. And you get some labs, and those are the labs here. So sodium is 134, potassium 4.4, chloride 103, bicarb 23. BUN is 54 milligrams per deciliters or 19 millimoles per liter. Creatinine is 2.4 milligrams per deciliters or 212 millimoles per liter. Protein is 5.8, albumin 2.8, normal would be 4. Bilirubin is slightly elevated, 2.7 milligrams per deciliters or about 950 micromoles per liter. Lactic acid is elevated, it's 4.6 milliequivalents, normal would be less than 2. When the CBC comes back, the white count's normal, it's 8.9, hemoglobin's low, 7.8. You don't know what a baseline is. Platelets are low, 98, pretty typical for cirrhotic. And the INR is mildly elevated, 1.6. So what are your next interventions? So you all have access to the chat feature, right? So why don't some of you put into the chat what you would do? Or if you want to unmute yourself and just speak up how you would approach this patient, treat this patient. So I think someone is speaking up, but I cannot hear it. It's too quiet. I'm sorry. Yeah, but so one person put in the room urgent endoscopy, transfuse packed red blood cells and FFPs. Good. What else would you do? The GI doctor, I can tell you, is going to say, you need to stabilize the patient first, and then I will come in and scope the patient in the ICU. Blood group, yeah, so type and cross-match, transfuse, yeah. Endoscopy, vitamin K. Yeah, octreotide, transfuse FFP. Yeah, you got most of the things and a few things that I probably wouldn't do. So we'll talk about that. So yeah, you would definitely transfuse some blood. And in someone who's actively bleeding, the hemoglobin that you measure does not reflect what their actual blood volume is. So you have to transfuse based on vital signs, basically, based on clinical status of the patient. In this patient, probably a good start is giving 4 units of packed red blood cells. We will give a PPI as well, pantoprazole, and then start octreotide, give a bolus, 50 mcg bolus, and then start a trip at 50 mcg per minute. And then you would do the endoscopy once the patient is stabilized. So just talking about some of the comments from the chat. So vitamin K, you could do that. It would not work immediately, right? It would take several hours to replete the missing clotting factors in the liver. FFP, we would not give FFP. Actually, the INR does not correlate to the bleeding risk in a patient, and people with cirrhosis can have an elevated INR and clot, actually, like have portal vein thrombosis. We would do a blood test that I'm not sure you all have available, but it's called a TEG or a ROTEM. The TEG is the thromboelastogram. And it's done a lot in the CV surgery world, and it is actually the recommended test to assess the coagulation and the blood product needs in cirrhotics. So no FFPs. And fluids, someone said fluids. Yes, we already gave fluids. So the patient really needs blood at this point. And then once the patient is stabilized, then endoscopy. And the discussion I often have with the GI doctors is they say, well, you need to stabilize the patient, then we'll come in and scope. But if the patient continues to bleed, the patient's not going to be stable until they have their varices ligated, right? So you start all these treatments and you get blood into the patient, and then you have the endoscopist come in and scope the patient. And I would intubate the patient who's actively bleeding, especially with a variceal hemorrhage. Seen some very bad outcomes if you don't intubate these types of patients. And then if someone needs a massive transfusion protocol, then it's a little bit different. Then you would give packed red blood cells and FFPs in a ratio 1:1 and platelets as well. And then cryoprecipitate and calcium and all these things. And often these patients with massive variceal hemorrhage actually do need a massive transfusion protocol type transfusion to survive. Okay, so now you have called the endoscopist and you do banding. What else will reduce mortality in this patient? And the options are A is transfusing packed red blood cells to a hemoglobin goal of 9 as opposed to a lower or higher goal. Calling the surgeons for an emergency orthotopic liver transplantation, transfusing the freshest units of packed red blood cells that are available in the blood bank as opposed to older units, or initiating ceftriaxone, 1 gram IV every 24 hours for 3 days. Which one would you do? You can put it in the chat again. So we have one person saying A. Transfuse to a hemoglobin goal of 9. And then a couple of people choosing D, giving ceftriaxone, and then someone choosing C, thinking about giving the freshest units first. Very good. We have a good spread here. Yeah. So the correct answer is D, ceftriaxone. And we already talked about a PPI and octreotide, so I won't belabor that. The ceftriaxone, actually, or other antibiotics as well, especially ceftriaxone and fluoroquinolones, has shown to lower mortality when you give it to patients with acute variceal hemorrhage. The transfusion goal in variceal hemorrhage has been studied. And the problem actually is if you transfuse to a goal that's too high, like a hemoglobin of 9, then the pressure in the portal vein or the portal system gets increased, and that will then subsequently increase the pressure in the varices, and then the varices will bleed even more. So over-transfusing these patients can actually be really dangerous. And so the goal should be 7. So in practice, we typically aim for reaching a hemoglobin of 8, because you want to, if a patient is actively bleeding, if you aim for 7, then probably most of the time your patient's going to be at 6. But if you aim for 8, then most of the time your patient will have a hemoglobin above 7, and that's the threshold. And the study that looked at that, I have the reference here from 2013, actually showed that the mortality was increased with the higher hemoglobin goal. And in real life, if someone is actively bleeding, it can be really challenging to not over-transfuse them. And I have done that, because they're pouring out blood from above and below, and you're just trying to keep up and keeping them hemodynamically. We go by vital signs. And then often these patients, especially if they need an MTP, a massive transfusion protocol, I've seen them get so volume overloaded that we have to put them on dialysis afterwards once their bleeding has stopped. All right. And so someone was asking if rifaximin can be initiated instead of ceftriaxone. So no, so rifaximin is for hepatic encephalopathy. It doesn't have a role here. So we usually use ceftriaxone because it has fewer side effects than the fluoroquinolones. And the reason you treat antibiotics is because these patients with a variceal bleed or any kind of GI bleed, really, they are a very high risk of getting infections, SBP or even bacteremia. And that's the mechanism why the mortality is reduced, because you treat their infection aggressively. So the endoscopic treatment that's recommended is what's called a band ligation. And if that's not feasible, then you would do sclerotherapy. But the band ligation is really what endoscopists do these days. And now if endoscopic therapy fails, or sometimes if we've at least stabilized the patient enough to go on to further treatments to lower the pressure in the portal vein, then we would do a TIPS. Now, a TIPS is contraindicated if the MELD score is too high, because then the patient just has too high a risk of hepatic encephalopathy. But if a TIPS can be used, this is indicated, that would be the treatment. And it depends a little bit on the situation, who needs it, but that is something that you would discuss with the GI doctor. In someone with a variceal hemorrhage, is a TIPS indicated, either as a rescue mortality or to make sure they don't bleed again. And the TIPS is basically creating a shunt between the portal vein and the hepatic vein. It's done by interventional radiology. They go on through the IJ, the internal jugular vein, and then they place a catheter between the hepatic vein and the portal vein. And basically that lowers the pressure in the portal vein, because now the blood is from the portal vein isn't shunted into the varices that then bleed, but is shunted into the systemic vein. But the problem is then the liver is bypassed, and that's why these patients with TIPS are at high risk for hepatic encephalopathy. Balloon tamponade is temporizing until you can do the endoscopy or do the TIPS. And sometimes I've seen the GI docs put in these esophageal stents, which is basically the same principle as balloon tamponade. The same types of stents, well, they're removable stents, but the same principle what they would put in if someone has a stenosis from a tumor or something. Emergency shunt surgery has a very high mortality. I've actually never seen that done. Yeah, and I mentioned the stent. Yeah. And that's usually the stents that they can remove again. Yeah. Oh, someone was asking, how does ceftriaxone reduce the mortality? It's because so many of these patients that bleed get infections. And so you either prevent infection or you treat it very early. But even if you give I've seen people get bacteremic with gram negatives like Klebsiella, even though we gave them ceftriaxone right away. Now, gastric varices are more difficult to treat than esophageal varices, as I mentioned, and require advanced endoscopic therapy and referral to usually a tertiary center in the US. And the GI docs basically inject a form of glue into these varices. Injection with epi and cautery are not effective. TIPS may be effective. And then the interventional radiologist can do something called a BRTO, balloon occluded retrograde transvenous obliteration. So it's just something to be aware of if you have an interventional radiologist that is familiar with this procedure can do this to discuss that with them. And banding doesn't work in gastric varices. Ectopic varices, like small bowel or somewhere there, you can do TIPS, the BRTO, and the surgical shunting. Again, I like a splenorenal bypass. That's what surgical shunting means. I have never seen that done. So someone already asked about a role of antibiotics in patients with cirrhosis and acute GI bleed. So just a little bit more data. In addition to what I already mentioned about that, so bacterial infections are present in up to 20% of patients with cirrhosis that are hospitalized with a GI bleed. And that means they're present at presentation when the patient comes in with a GI bleed. And then half of the patients that come in with a GI bleed with cirrhosis, then they develop an infection while hospitalized. And that increases the mortality. And so there's been multiple trials that have evaluated the effectiveness of prophylactic antibiotics in cirrhotic patients, and they showed a reduction in getting an infection, reduction in mortality, and it may reduce the risk of recurrent esophageal variceal bleeding. And preferably, you would give the antibiotics before endoscopy. So how long would one give ceftriaxone? In that question, I think it said 3 days. Usually we do 5 days. Yeah. And then obviously, if they have an infection, if you diagnose an infection, then you would treat according to the guidelines for that infection. So just to mention the portal hypertensive gastropathy, because you will see that mentioned on the endoscopy reports quite a bit in these cirrhotics. And it's very, very common, but it typically doesn't cause significant enough bleeding for the patient to have massive hematemesis and become unstable. What happens is that basically you have very friable mucosa and you have these dilated vessels in the gastric wall and they bleed when they rupture. The higher the pressure of the portal vein, the higher or the greater the severity of portal hypertensive gastropathy. And there are some cases where severe portal hypertensive gastropathy just leads to diffuse oozing and leads to significant anemia. But it's not the patients that like keep throwing up blood in front of you. It's more the patients that maybe have ongoing melena and are anemic and you have to keep giving them blood. And then you do the endoscopy and then you see the portal hypertensive gastropathy. It can be confused on endoscopy with GAFE, which is a form of angioectasis, like dilated blood vessels, which you can also see in renal patients, ESRD patients, and has an association with aortic stenosis. And so those can also occur in cirrhotics, but are much less common. And then the same principle that people can get the portal hypertensive gastropathy, that can happen in other parts of the GI tract. So you can have a portal hypertensive colopathy or enteropathy. And the typical clinical presentation of that is someone has a GI bleed, maybe ongoing melena, you do the endoscopy from above, and you don't really see significant enough bleeding. The GI docs do the colonoscopy, and then they see the portal hypertensive colopathy, and that's the cause of bleeding. There's no specific intervention, there's nothing you can inject or ligate there. You just have to lower the portal pressure. You can, for portal hypertensive gastropathy, you can try to prevent it with non-selective beta blockers. Propranolol is what we typically use. If there's chronic bleeding, you would again use propranolol, replete iron, and blood transfusions as needed. Acute bleeding, maybe there's a role for octreotide. PPI is controversial. We usually give both octreotide, PPI. Blood is needed. Antibiotic prophylaxis. So that's true not just for variceal bleeders. I want to make sure you all understand it. Any type of cirrhotic has a GI bleed, even if it's a bleeding ulcer, they need antibiotic prophylaxis. And then they also have a very high risk of getting hepatic encephalopathy. So you have to be really aggressive of treating them with lactulose and rifaximin and making sure they have 2 to 3 soft bowel movements a day. That's how we titrate a lactulose. Okay, so before I go on to hepatorenal syndrome, Let me ask you if you have any questions about a variceal bleeders, because this is probably the most scary and very common complication of cirrhotics that we see in ICU. Any questions about this part? You could unmute yourself, or you can put something in the chat, whatever works. All right, I don't see any questions, so I'll move on to hepatorenal syndrome. So I'll try to teach a little bit about this topic by going through a case. We'll have a few questions about that case. We have a 35-year-old man with decompensated alcoholic liver cirrhosis. Comes to the emergency room with a one-day history of confusion. He's lethargic, has diffuse abdominal pain, is nauseated, and has decreased urine output. At home, he's on furosemide and spironolactone because he has chronic ascites. He's a former alcoholic who quit drinking 5 months ago. His physical exam is remarkable for a chronically ill-appearing male. He has muscle wasting. And when you try to talk to him, he's kind of sleepy, but he's arousable. He knows his name, but nothing else. And he has hysterexis. And when you listen to his lungs, there's decreased bibasilar press sounds, and he has some bibasilar crackles. His abdomen is distended. You can feel tense ascites. There's mild diffuse tenderness, and his bowel sounds are quite hyperactive. There's symmetric bilateral lower extremity pitting edema to the thighs. So now you check the blood work, and the sodium is low, it's 122, potassium is 5.1, chloride is 97, bicarb is 17, creatinine is 2.7 milligrams per deciliters. And sorry, I didn't include here how many micromoles per liters that is, but it's basically 3 to 4 times above normal. BUN is 65, so that's pretty high. Glucose is 75, so it's lowish normal. Hemoglobin is 8.2, it's down 2 points from a month ago. Platelet count's low, 71. White count is 50 with a left shift, 87% neutrophils, 5% bands. Bilirubin is 6.3, AST 112, ALT 155, ALP is 181, protein is 4.3, albumin 2.1, and his ammonia is elevated, it's 110. His INR is 2.4, it's elevated as well. You calculate a MEL sodium score, which is basically a prognostic marker telling you how what the expected mortality in the next 3 months is for this patient. And it is being used in assessing candidacy for liver transplantation. But 36 is pretty high. So again, you have low sodium, you have elevated creatinine and BUN. So what tests would you obtain to work up the acute kidney injury? Again, creatinine is 3 to 4 times elevated and up from his baseline. So A is urinalysis, B is a spot urine sodium, creatinine, and protein, C is renal ultrasound, D is a paracentesis, acidic fluid analysis, E is urinalysis and the spot urine electrolytes, and F is all of these tests. So some people will do a renal ultrasound, yes. So with the point of doing a renal ultrasound, and if you're trained in bedside ultrasonography, you can do it yourself, is to make sure the patient doesn't have hydronephrosis, right? Then there's no obstruction. So we have a good mix here. Mainly C, E, and F. Yeah. Yeah. So you would actually do all of the above. Yeah. So A and B will help you differentiate the cause of the AKI. The renal ultrasound will help you quickly rule out hydronephrosis. D, you need to look for SBP, right? You suspect that based on the physical exam. And then, yeah. So now I'm giving you the results. Okay, I'm just checking the chat here. The UA is basically normal. Particularly, there's no protein, there's no blood. Urine sediment, there's no RBC or WBC casts. So no casts. Casts you would see in glomerulonephritis, right? That's why you're looking at that. Or muddy brown casts in ATN. The urine sodium is less than 20, that's low. You calculate a FeNA, fractional excretion of sodium, 0.01%. So that's low as well. Tells you pre-renal. The renal ultrasound, kidneys are normal sized. If they were very small, that would indicate the patient has underlying CKD, chronic kidney disease. You would not suspect that in this case, because I told you the creatinine was normal 4 weeks ago. And there's no hydronephrosis. So then you do the diagnostic paracentesis, not therapeutic, just diagnostic. Take 60 mils or something and send it to the lab. And these are the results. The white cells in the ascites are 1,342. It's 89% neutrophils, also known as PMNs, polymorph nuclear cells. And you actually get a gram stain and it shows gram-negative rods. Now, I'm telling you that's very rare. Most of the time, the gram stain is negative, even if there is an infection present. And maybe another pearl, when you send the cultures, don't send them just in a regular tube. You have to take the blood culture bottles and inoculate the ascites into blood culture bottles, an aerobic and anaerobic one, directly at the bedside, and send that to the lab. Has a much, much higher yield than if you put it in some other tube, sterile tube first, and then send it to the microbiology lab. So which of the following findings defines the diagnosis of SBP, spontaneous bacterial peritonitis? So the options are basically, is it based on the white blood cell count in the ascites or the polymorph nuclear leukocyte count? And then what's the cutoff? Is it 200, 250, or 500? All right, very good. The people that have answered so far, they all got it right. E. It's a PMN count in the ascites of more than 250. So now let's summarize what's wrong with this patient in this case. So we've diagnosed him as SBP. His PMN count ascites, 89% of the 1,342 is 1,194. The cultures from the ascites eventually grew a pan-sensitive E. coli. Patient also has hepatic encephalopathy. Told you he was confused and had asterixis. And actually already has an ammonia level that was elevated, though the ammonia level does not necessarily correlate with the presence and the degree of hepatic encephalopathy. It's more clinical diagnosis. And he has acute kidney injury. Over the course of his treatment, the creatinine went even higher into 3.6 milligrams per deciliter. That's from 239 to 318 micromoles per liter over the next 3 days. And then the patient stopped making urine. So less than 4 mils per day urine output. So what do you think is the cause of AKI in this patient? And I already gave you all the data to tell me. Is it ATN? Is it HRS, obstructive uropathy, MPGN, IgA nephropathy, or BREMing? All right, so it is HRS, right? ATN, you would see a high FeNA, you would see muddy brown casts. Obstructive uropathy, you would have diagnosed on the renal ultrasound. MPGN, IgA, you would see blood in the urine. And with MPGN, you would see RBC casts. So HRS is a common cause of AKI in patients with liver cirrhosis. You can also see it in acute liver failure. And it's a diagnosis of exclusion after ruling out all other causes of AKI. It is associated with a poor prognosis. A cirrhotic who gets AKI, and typically that patient would be in our ICU, has a 30-day mortality of 29 to 44%. And the pathogenesis it's basically functional renal failure caused by the hemodynamic changes that occur in cirrhotic patients with ascites and portal hypertension. It's renal hypoperfusion, basically. So a couple of years ago, the American Association for the Study of Liver Diseases came up with new definitions of HRS. You may remember HRS 1 and 2. That's what I learned when I trained. And HRS1 is basically called HRS-AKI now, and HRS2 is basically called CKD in cirrhotics now. So HRS-AKI is the form of AKI that occurs only in patients with cirrhosis in the absence of hypovolemia. How can you ensure the patient isn't hypovolemic? You make sure their volume repleted, usually give them some albumin. And you cannot have any significant abnormalities in kidney histology. And then the HRS-CKD is someone who has cirrhosis and has a reduction in GFR less than 60 mils for at least 3 months. All right, sorry, I was just making sure there's nothing in the chat. Yeah. Diagnostic criteria are cirrhosis plus ascites. And then the standard KDIGO criteria for diagnosing AKI, increase in serum creatinine of more than 0.3 from baseline within 48 hours, or increase in serum creatinine of 50%, which is known or presumed to have occurred within the preceding 7 days. And no response, no improvement in renal function after 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin. Usually we give 1 gram per kilogram body weight per day. You need to make sure the patient doesn't have shock, because then the patient might actually have ATN. You need to rule out the use of nephrotoxic drugs and stop those if the patient's getting them, like NSAIDs, aminoglycosides, iodine contrast, and no signs of structural kidney injury. So no proteinuria, no microhematuria, and no obstruction. And then just as a reminder, this is not a renal talk, but just as a reminder about, sorry, I'm following the chat here. So the 3 different KDIGO stages for AKI defined by increasing creatinine. And there's also urine output criteria, which I haven't listed here. Just remember, in cirrhotics, the problem with estimating kidney function is that the cirrhotics, they don't have muscle, and they have very poor appetite, so they have decreased protein intake. And so the production of creatinine and urea in the body is typically reduced. And so the creatinine can be falsely low. It doesn't necessarily reflect the true GFR. The GFR may be actually much lower than you would think it is based on the creatinine. And then if you really want to know what the GFR is, you can measure it. Do a 20-hour. The urine sediment in HRS is typically normal, unless you put a Foley in, cause some bleeding. I already mentioned urine sodium is typically low, less than 10. If it's high, then it's probably ATN or something else. And the patient can be making urine and can be oliguric. In the later stages, they're typically all oliguric. And I'm just gonna skip this slide here. The hyponatremia increases the risk of HRS, hepatic encephalopathy, and SBP, and increases mortality. Let me just skip through that here.
Great.
Okay. Now, one question that comes up all the time is, do diuretics cause HRS? And the short answer is no. How do we differentiate diuretic-induced azotemia, renal failure, and HRS-AKI? So diuretics obviously can cause AKI if you over-diurese someone, or if you cause overly rapid fluid removal. But if that is the cause, then you stop the diuretics and you give fluids back if you've dehydrated the patient. And if it's diuretic-induced AKI, the creatinine will improve. But if it's HRS, the AKI will worsen even after stopping diuretics and giving albumin. So how would you treat the patient from the case with SBP, HRS, AKI, and hepatic encephalopathy? And there's a bunch of options, and the answer is that many of them are correct. And so I'm just gonna go through that and talk about antibiotics was some of the options, about albumin, volume replacement, and then vasoconstrictors, because that's basically the strategies. So antibiotics, it's 3rd-generation cephalosporins, ceftriaxone, unless you have a lot of multi-drug resistant organisms. So where I practiced in Houston, we actually did have a lot of MDROs. A lot of patients were retreated with cephalosporins or fluoroquinolones. And so if I had a patient with SBP or cirrhotic with suspected SBP in shock in the ICU, I would probably put them on meropenem, just because the chance was so high that they had a bug that was resistant to ceftriax. Then you give starting antibiotics. 2 days later, you do a repeat paracentesis. And if the PMN count does not decrease by more than 25%, you need to broaden antibiotics. And you need to look for secondary peritonitis, like a perforated bowel, by doing a CT scan. And then you treat for 5 to 7 days. Obviously, the patient needs to defibross and get better before you can stop the antibiotics. Then you would also give the patient albumin. The studies have used 1.5 gram per kilogram body weight on day 1 for the SBP, right? And for HRS-AKI, you would basically also give 1 gram per kilogram body weight on day 1, and then maybe 50 grams per day for the rest of the time. 20 to 80% improve with the treatment. So just to make sure I don't confuse you here, maybe I went through that a little bit too fast. So there's different albumin dosing for patients with SBP. SBP is 1.5 grams per kilogram on day 1, and then 1 gram per kilogram on day 3. And if someone has HRS-AKI but doesn't have SBP, then you would basically give them albumin every day. And honestly, I usually do 25 grams Q6 hours or Q8 hours. I don't think there's very good studies. And it does, giving albumin does improve the outcome, though, in both HRS-AKI and SBP. And the patients in SBP that benefit most from albumin is those that have underlying renal dysfunctions and those that have severe hepatic decompensation. Albumin also prevents progression of AKI. Vasoconstrictor treatment. So norepinephrine plus albumin is what we have in the US, and it's equally effective as terlipressin, which we do not have in the US, but which they use in Europe. And there's more data, just more studies about terlipressin. And what's our goal map? You would increase from baseline for at least 10, or titrate the norepinephrine so that the urine output increases by at least 200 milliliters every 4 hours. Using midodrine plus octreotide is much less effective than using terlipressin or norepinephrine. And then you give albumin. TIPS is not recommended. And in my setting in the US, the nephrologists often come to me and say, I have this patient with HRS-AKI on the floor, and they're not getting better with stopping the diuretics and giving them albumin and volume repletion and stopping all the nephrotoxic drugs, and they're getting worsening renal failure. Can you take them to the ICU and start them on norepinephrine? And yes, there is actually evidence behind doing that. And so we usually do take them to the ICU, which is the only setting where we can give norepinephrine. And depending on the study, you would raise the MAP by 10 to 15, or some studies say raise the MAP above 80. And if someone is interested, there's a paper from 2011 from the American Journal of Kidney Disease that studied that. And it actually showed that it does help, it does work in HRS. How long should you treat HRS patients with vasoconstrictors? It's basically expert opinion. We usually give them a trial. I don't think we give them a trial of 2 weeks in the ICU, but with norepinephrine at least. But a few days, and if they don't get better and if they're not liver transplant candidates, then you probably have to call palliative care. And the initiation of dialysis is the same in a patient with HRS-AKI as with any other patient. We usually start them on CRT because their blood pressure is low and they don't tolerate the rapid fluid shifts with intermittent hemodialysis. The ultimate treatment is liver transplant. I'm gonna skip through that. Yeah. There's a few drugs you want to avoid in any cirrhotic, really. NSAIDs. If someone has renal dysfunction, the ACE, ARBs, alpha-1 blockers, dipyridamole, you want to avoid nephrotoxins. And just think about, does the patient really need contrast before giving it? And I'm going to skip through that as well in the interest of time, but there are some data about the role of albumin in treatment of cirrhosis and portal hypertension. The expected mortality is about 50% in HRS. I mentioned it earlier. All right. So the management of ascites is not so much an acute ICU issue, but you'll see a lot of cirrhotics that have ascites, so it's important to know. And the mainstays are basically evaluate what the cause is and put them on fluid restriction, low salt diet, and start Lasix and spironolactone at that ratio, 40 to 100, titrate up every couple of days. Therapeutic, large volume paracentesis, and then TIPS, temporizing measure, and liver transplantation is the eventual cure. And I'm gonna skip through this question. It's again asking about appropriate fluid, and it's albumin. All right, so okay, I'm seeing some messages here about no voice. I hope you can all hear me. Pretty sure I have my audio on.
Yes.
So I have a few more slides about like hepatic hydrothorax and so on, which are much on portopulmonary hypertension and so on, which are much less common. So let me stop my share here. And since it's almost 6 o'clock, ask you guys, do you want me to go through those slides or just stop here and leave 5 minutes for questions? It's up to you.
Thanks, Dr. Andrea. I think we could leave those few minutes for questions, and perhaps maybe you could share the slides with me, and then I can share with the group later to go through.
Yeah, I can definitely do that. Yeah, I don't have much left. I wanted to basically talk about a variceal hemorrhage, about a HRS. I think
perhaps I think we could definitely plan another day to continue this webinar on another day. I see a lot of good comments on the chat that they enjoyed this presentation, and I agree with them too. So if anyone has any questions, we have a few minutes. Feel free to unmute yourselves and you can ask. Yes. So I guess there was some interaction going on while the presentation was going on. Most of them asked their questions there, it seems.
Delirium.
Yes, Mazhar, yes. Go ahead.
I'm sorry?
Dr. Mazhar has a question. Yes, go ahead.
Hello, good evening. Thank you for that comprehensive presentation. My name is Dr. Mazhar. I'm actually a nephrologist practicing in Tanzania. I just wanted to ask you a naughty question on the question about hepatorenal syndrome that you presented the case. So obviously the answer would be HRS, given that this is a HRS or a liver topic. But my argument would be like, why wouldn't it be pre-renal AKI? The reason why I say this is that the patient had, high urea to creatinine ratio. The patient had a very low FeNA, and also that the patient had no urinary casts on urinary microscopy. So that would be a telltale sign for, pre-renal AKI. Of course, I mean, the pathophysiology would kind of be in keeping with pre-renal AKI. Most of these patients actually third space, so they are intravascular depleted, and that would probably lead to that. And given that this wasn't a cirrhotic patient, it probably would be pre-renal AKI, but it's just for argument's sake. Your thoughts, please. Thank you.
Yes, thank you. That's an excellent question. So, as I mentioned, HRS AKI is a diagnosis of exclusion. So you would want to exclude pre-renal AKI from volume depletion, right? First, and how would you do that? You would make sure the patient gets adequate volume repletion, give them some fluid, some albumin, and then once they're euvolemic and they still have ongoing renal failure, then that would indicate it's HRS AKI. But sometimes it can be difficult to distinguish, and patient can be pre-renal and dehydrated, and then you volume replete them, and they still have renal failure, and then they actually had both pre-renal and the HRS, but only one is easy to treat with volume repletion. And the FeNA and the urine sodium would be low in both conditions, right? And with HRS AKI, you wouldn't see any, you would see a normal urine sediment. So again, that would be the same as with the pre-renal AKI. And the high BUN, I think it was 65 and 2.7. So yeah, definitely a little bit higher than 1 to 20. But remember, the BUN can be high for other reasons as well, most specifically for
Yes.
GI reasons.
Yes,
Mm.
absolutely. Yeah, thanks, Prof. That is why these patients are so critically ill, and it's difficult to differentiate between the two pathologies. So one has to have a very high depth of suspicion to make a diagnosis in this manner.
Yeah, and the patient, he was confused, and there may very well have been an initial component of dehydration. He was confused, had encephalopathy, had SPP, and so
yeah,
he probably wasn't eating and drinking much at home.
Yes.
Yeah,
Thank
and
you,
then
Prof.
sure, thank you. There was a question about delirium in HRS AKI. So. I mean, there's obviously hepatic encephalopathy, which you would treat with lactulose rifaximin. You would treat the infection, and you would treat the hyponatremia, and treat any other cause of delirium that you can find. I mean, HRS AKI by itself shouldn't cause delirium. If someone is uremic, sure, that can make them confused. I wouldn't expect that with the labs that I showed you. I think that particular patient was confused because of infection and hepatic encephalopathy. I'm not sure if that answers your question, but basically try to find out why your patient is confused and treat the what you can find. Especially look at the drugs. A lot of medications that we give patients with delirium. And a lot of drugs accumulate in renal failure. You know, cefepime is a drug we use like candy in the US because we have so much resistance already to piperacillin tazobactam. And so cefepime is often our go-to first-line antibiotic for infections, and it causes a lot of neurotoxicity in the setting of renal failure.
Thank you, Dr.